Hi friends. Now in this episode of Unplugged, I will try to look at a case from in a similar perspective as a real radiologist looks like. I want you to see how we see the image in the hospital and how we make a diagnosis. So I'm now going to show you a triple phase CT of a person who had a suspected liver pathology, a liver mass on an ultrasound abdomen, and advised a CT abdomen, triple phase CT abdomen with us. So let me show you first this is the how first you take a scout film. On the scout film you plan how the CT abdomen will be done, and first you do a plane study. This is how a plane study of the abdomen would look like. So how do you know this is a plane study? You can see for yourself that the blood vessels, they don't show any contrast. So always remember, this is the right side, this is the left side, anterior, posterior. You can see the mediastinum, you can see the vessels with no dye in it. Let's try to look at the plane image. So it's always a good idea to start with the lung window, because when you're looking at the lung basis, why not look for any focal lesion in the lung or anything, and we think there is some focal lesion in this paracardiac area here, but we're not really of anything of much significance. This is a 70-year-old man. We are looking at the CT scan, and let's try to come back to the abdominal window. Now look at the liver. Are you able to identify this faint hypodense area? And when we go down, do you feel this right lobe shows this hypodense area? And probably this must be the mass that you must be seeing on the ultrasound of the abdomen. And when we go down, you can see the spleen on here, this side. You can see the stomach, some atherosclerotic changes in the aorta. Nothing much. You see here now this is your area of your portal vein. Now when I look at the portal vein, it looks a bit expanded on this plane study, but we'll try to find out on the contrast study more. And this area looks much more busy. You see a lot of standing here in the hepatogastric area. We'll try to see all this in the contrast study later on. Now when I go down around the portal vein, you can again feel that this area looks a lot more busy than it should be. You see a lot of standing. And when we go down, you see the pancreas, you see the kidney. Again, on the para-aortic area, you see something more than what you should be seeing in the normal person. So we have a fair impression on the CT of the non-contrast CT that we are looking at something to do with the liver, male patient, old male, something to do with the liver, some multifocality in the area. Maybe let's look at the arterial phase and let's try to find out what we are looking at. Okay, so let me bring the image into you. Now you can clearly see this is the post-contrast arterial phase image, and you can see there is contrast enhancement in the blood vessels, which we did not see in the plane image. Now when we go, you can see this is the left atrium for you, for the people who are not initiated. This is the descending aorta. This is the right atrium that you can see, the aortic root, and we are going down from here. So keep looking at the right atrium that I marked for you. We are going down. You can see this is the area of the inferior vena cava. We feel there might be some expansion here. It looks a bit expanded, and then the same area in the liver where we saw the hypodense area, you see some enhancement. And when we go down and we are going towards that area in the right lobe where we saw, if you remember, that area looks diffusely abnormal. You can do a little bit of windowing to make it more visible for you. Now look at this. So in that area that we saw hypodense area, you can see there is enhancement in the arterial phase, and you can see a lot of corkscrew like vessels. That again tells you that maybe we are looking at some tumoral vascularity, neovascularization. See this enhancement. That area is picking up the dye in the arterial phase. And it is all heterogeneous. There is a lot of heterogeneity to the appearance. And when we go down towards the image, okay, you can't really appreciate the portal vein, but we'll try to look at it in the venous phase. And when we look at this right lobe, it looks diffusely abnormal, shows enhancement in the arterial phase, shows some corkscrew like vessels. And even the gallbladder, if you look at the gallbladder on the top here, looks a bit contracted with some thickened wall. Let's try to make sense in the further imaging here, but We know we are dealing with a multifocal hepatic lesion predominantly involving the right lobe, with a lot of heterogeneity, lot of arterial phase enhancement with some corkscrew like vasculature, telling us there is some tumoral vascularity here. And we know we are dealing with a malignancy. This is not it's looking aggressive to us, it's not looking benign. Now when we go to the portal venous phase, now let's see if we can appreciate. So when you repeat the CT in the portal venous phase, you can see the lesion now, and you can see a lot of those areas which were taking up the dye in the arterial phase are showing washout. So they are becoming, as compared to the liver, they are becoming hypotense. But can you appreciate some other finding here? Okay, let's see. Let me trace it for you. Now let me trace the portal vein for you. This is your portal vein. Let's trace it as it goes towards the liver, and you saw that busy area that we see. Can you see there are so many collaterals here? Why? Because you can see the tumor is extending into the right branch of the portal vein. So can you see how the right branch of portal vein that we saw on a plain CT was looking expanded? So we can see the tumor is extending into the right portal vein here, and you can see it now. I'm going to do a little bit up and down so that you can follow how the tumor is showing the vascular invasion into the right branch of portal vein. You can see the left branch clearly, but the right branch is totally invaded by the tumor. Again, a typical feature of hepatocellular cancer, where you see the invasion into the vessel here. And let's try to trace the aorta, and we saw that. Now look at that para-aortic area. This is what we saw on the plain scan. Definitely there are para-aortic lymphadenopathy here, which we can clearly appreciate now, because the dye helps us. Because the vessel is showing the uptake of the dye, but the lymph nodes are not enhancing, we can easily now make up there is para-aortic lymphadenopathy, there is a liver mass, heterogeneous, showing washout in the portal venous phase, enhancement in the arterial phase, multicentricity, diffuse involvement, neovascularization. You can see there is invasion of the portal vein with collateral formation. All this is pointing towards a diagnosis of primary malignant lesion of the liver called as hepatocellular cancer. Now we can also look at the disease in the delayed phase. When you look at it in the delayed phase, often in HCC you will see a rim of enhancement forming a capsule around it. That is again taken as very typical for HCC. We can't appreciate in this patient, but in the delayed phase, I hope you can see the invasion of the portal vein by the tumor very well. You can see you can see the tumor thrombus in the vein. Now the thrombus in the portal vein can be bland, can be malignant, and we look at the contrast enhancement. So that is why we have to look at it in the plain study and compare it within the contrast enhanced image. If it is a tumoral thrombus, it will show enhancement. So now if I try to summarize what we saw in this patient, we saw heterogeneous hepatic lesion involving almost all the segments of the right lobe here, and you saw heterogeneity, arterial phase enhancement. Hepatocellular cancer typically shows enhancement in the late arterial phase around 35 seconds after contrast enhancement. You saw arterial phase enhancement. HCC is typically supplied by the hepatic artery that leads to that arterial phase enhancement. In the venous phase, we saw the washout. And in the delayed phase, when you do in the parenchymal phase, you might see a capsule around it, which we could not appreciate in this patient because of the infiltrative nature of the disease in this particular case. And we also saw vascular invasion, which is we could directly see the portal vein thrombus and how the tumor is extending into the portal vein. We saw the expansion of the vein. We saw the enhancement of the thrombus, telling us that this is not a bland lesion. This is how you approach. And we saw retroperitoneal para-aortic lymphadenopathy as well. And we saw a lot of collaterals in the periportal area and in the gallbladder fossa. If you notice now that in the gallbladder fossa, you can see some vessels. Those are the collaterals that are seen as a result of the venous thrombosis. Okay, and now let me show you the collateral. Now this is what we saw in the image before also. You can see a lot of collaterals here. So this entire area that looked very busy on a plain scan was because of collaterals, which is easily appreciable on a contrast study. So the value of contrast enhancement is that it made the lesion more easy to detect. And the pattern of enhancement in the various phases is the key to identifying a liver lesion. We have to look at the lesion in the arterial phase, in the portal venous phase, and in the delayed phase to actually make a diagnosis. So I hope this gave you an insight, because many of you keep discussing and think, because in real life we don't look at, now can you see, we don't look at a single image, we scroll down. Okay, and that is the key to understanding the radiological anatomy. Now things become more clear. Now if you try to trace it, now look at the inferior vena cava, look at the left hepatic vein, right, and you can see that tumor is actually involving even the right hepatic vein. It is involving the hepatic part of the IVC, the portal vein. All that vascular invasion is very typical of hepatocellular cancer. Now when we look back at the age, 70-year-old male, typically HCC is more common in male. Older male are the typical people, and look for the risk factor for HCC, which would always include the hepatitis and the alcoholism. We have to keep all those things in mind when we look at a CT like this. But I hope now things would become a little bit more softer for you, that okay, it is not just about one image, it's about scrolling down, looking up and down, trying to find where we are. And now let's trace, if you're a resident, let's look at the pancreas with me and look at the portal vein, portal vein, portal vein, portal vein, and you will see the thrombus. Okay, don't worry, you will see it, you will see it, you will see it. And now here you see it. Can you see this? And this is how a typical exam case of a resident would be. But if I have to show to an undergrad, it would be a single image. They will show you a liver lesion, a portal vein invasion, and they will look at, what do you think this is? When you see such an appearance, first thing that should come to your mind should be hepatocellular cancer. So I hope you enjoy this episode of Unplugged. Do let me know if you enjoy the cross-sectional anatomy and the diseases, and if you want me to make a video on any other case, I'm most happy to do it. Just let me know in the comment section. And I would also strongly recommend to everybody, do look at the playlist of DAMS Unplugged. We have done maybe by now maybe approximately 100 videos in the past where we have discussed multiple diseases with multiple viewpoints. Please look at them, and in your free time, just scroll through them. There's so much of knowledge that we have actually shared through the social media in the past. Do look at the playlist of DAMS Medicine Unplugged. Do let me know that if you saw any previous video, you enjoy it. Do look at them. I'm sure you will enjoy them. We have covered a lot of things like bone tumors, brain tumors, kidney tumors. We've looked at many things in the past. I hope you enjoy and this episode of Unplugged, and do write to me if you like this approach of scrolling the images in the workstation like mode for you. Thank you.